Hey everybody, welcome back to another video in our January series on cooling for HIE. This week we have a presentation by a nurse from Calgary. Her name is Jan Lind, and she is going to give you an algorithm of care for babies with HIE in her unit. They use the acronym HIBERNATE, HIBERNATE, and each of those letters stands for a different component of care that we need to look for at the bedside. This is a complete presentation, A to Z, of everything that you need to know about taking care of babies at the bedside undergoing cooling for HIE. So it starts with H, hypothermia, which we all know 33.5 for 72 hours. But beyond that, there are so many variables that contribute to the success of cooling and to babies' outcomes. So you are going to truly enjoy this presentation from Jan. She presented this as part of the general sessions at our 2021 One conference that we did online. Everyone loved it. And this is just one of those lectures that you can go back to over and over again. It's a great resource for you, for your team. And I hope that you'll enjoy being able to watch it again and again here on our YouTube channel. So speaking of our YouTube channel, if you have not already, definitely go to our channel and hit that subscribe button. That really helps us out a lot. It helps us to bring you more free content. And if you'd like to get any of the resources related to this or any of the videos in our series this month on cooling for HIE, go ahead and either scan the QR code here on the screen or click the link in the show notes below, and you'll be taken to a page where you enter your name and your email, and then you will be notified when our videos go live every week, as well as you'll be able to download slides and other resources. So without further ado, I hope you enjoy this presentation from Jan from our 2021 One conference, and I will see you at the end.
Our next presenter is Jan Lind, and she's going to be talking about neuroprotective nursing care, more than just a cool cup. So Jan began her nursing career in London, England, but has lived and worked in Canada for over 20 years. Her career has encompassed a strong clinical background working as a staff nurse, clinical nurse educator, transport nurse, and nurse clinician. She has been a neonatal nurse for 26 years. She has a special interest in neonatal neurocritical care and is a co-lead for the Nursing Neonatal Neurocritical Care Program at Alberta Children's Hospital in Calgary, Alberta, Canada. She is a member of the steering committee for the neurocritical care and was involved in the development of the neonatal care bundle for management of infants with HIE. Jan is also the co-chair for the Parent Partnership and Care Committee and is a strong advocate for family integrated care. So we're going to have Jan come in.
Hello. Hi.
Hi. How are you?
Hi there. I'm good, thank you.
Welcome, welcome. So we're excited to hear your talk today. So I'll just let you go for it.
Sounds good. Lovely. Okay. Thank you so much for the invitation to speak here at the 2021 One conference. I've been inspired by so many of the speakers this year and this conference, and I'm honored to be able to share our model of neuroprotective nursing care here at Alberta Children's Hospital in Calgary, Canada. And hopefully I can try and inspire some of you guys too. So the objectives of my presentation today are to outline at least two components of a model of neuroprotective care for infants diagnosed with a potential brain injury, and to discuss and recognize the impact that focused neuroprotective nursing care can have on improved patient outcomes. I have no disclosures, except that I'm just a little bit afraid of bears. So what is neuroprotective care? Neuroprotective care involves processes and strategies used to protect against neuronal injury or degeneration of the central nervous system. The goal is to limit the damage of an acute injury and optimize cellular function to improve both short and long-term neurological outcomes. And it really encompasses all interventions that help promote normal development of the brain. If any of you have ever visited Calgary, you will know that we are close to the Rocky Mountains, and where there's mountains, there's bears. So we took a closer look at what happens to our furry friends during the cold winter months during hibernation. And studies in animals suggest that the unique physiological state of hibernation can actually provide several neuroprotective adaptations. So here's a few fun facts about bears. So during hibernation, a bear's body temperature drops by 7 to 8 degrees, from 37 to about 29, 30 degrees. Their heart rate slows down from about 50 to about 2 to 10 beats a minute. They have the ability to suppress their metabolism by 75%. And in a large bear, they've got about over 1 million calories of energy that can be stored in their generous fat rolls. So bears are actually in an awake state, but in a reduced metabolic state called a torpor that significantly reduces their oxygen consumption. So extreme caution is needed when you come across a hibernating bear. If you wake them suddenly, you can actually put them into a sort of cardiac arrest, or worse still, you'll have a really angry bear on your hands. So the moral of the story is don't poke the bear. And the same caution is needed for our cooled babies. We train our team to recognize when the baby is in a sleep state so that we are careful not to startle the baby, as the main goal of care is to keep them calm, reducing their metabolic needs. So here in HCH, we took this concept of hibernation and built our HIE hibernation protocol. In an effort to try and make things a little less scary and more comforting for families, we likened the therapeutic hypothermia treatment of the baby to that of a little bear going into a state of hibernation, entering a short 72-hour winter sleep. Parents receive one of our teddy bears, a cool cub, and get to keep their baby's brain net, which we use as a guide for our EEG placement, as a memento of their time in the NICU. This approach really seems to help parents cope with the unnatural feeling of their baby's body temperature being cooled, softens the thought of their baby being in any discomfort from the cooling therapy. So what does hibernating in a NeuroNICU look like? We developed a mnemonic, HIBERNATE, to help identify the priorities of neuroprotective nursing care. Strategies are aimed at limiting damage or lessening the evolution of the insult, thus promoting the highest possible integrity of cell function. So let's take a closer look at these strategies. Therapeutic hypothermia. Therapeutic hypothermia, of course, is the standard of care for those infants that meet criteria for cooling, and the only proven treatment in the subacute phase of asphyxia-induced brain injury. The body temperature is rapidly cooled and reduced to 33 to 34 degrees. At ACH, we're a tertiary center for infants that are outborn, so cooling is usually initiated at level 1 or 2 centers following consultation with our level 3 sites. Cooling is continued for 72 hours from the time that target temperature is reached. And some of the beneficial effects of cooling, just to refresh, are a decreased cerebral metabolic rate, which is reduced by 5 to 7% for each 1 degree in body temperature drop, a reduced edema, hemorrhage, and neutrophil infiltration, a slowing down of brain cell depolarization, a decrease in the accumulation of excitatory amino acids, reducing intracellular calcium accumulation, and a decreased release of free radicals, protecting the cell from oxidative damage during the reperfusion phase. And it also helps to maintain the integrity of the brain cell membrane. And cooling the infant can prevent the evolution of the injury to cellular apoptosis or programmed cell death, but it can't actually reverse the necrosis. We unfortunately can't reverse the damage that's already been done. Serious adverse effects of cooling are rare and are likely probably due to the severity of the illness rather than therapeutic hypothermia itself. So some complications relating to HIE may worsen, though, with hypothermia. Cardiac arrhythmia, bradycardia with a prolonged QT with an increased risk of ventricular fibrillation, coagulopathies, abnormal renal function, electrolyte disturbances, some bone marrow depression, elevated liver enzymes, metabolic acidosis, and a risk of subcutaneous fat necrosis. So we'll take a look at some of these complications throughout the presentation. It's important to recognize that cooling is not a benign procedure, so an infant must fulfill clear eligibility criteria. It can not only cause physiological complications, but also usually means the separation of a mother and child, another adverse stressful event for both mum and baby. Which leads us to our next important strategy for neuroprotection for the infant. And I love that this comes here because so often family presence is discussed at the end of all of our other interventions. But as we have learned even throughout the conference, integrated family care is so important, both for the short and long-term outcomes of the infant. So we know that for many of our families, it's an unexpected trauma, a healthy pregnancy where complications arise sometimes just only at delivery. The journey has been described as an emotional roller coaster with a range of intense emotions, that from disbelief to guilt to honestly just holding on to hope. And then many of our families, as we know, are left with this uncertainty of what their future looks like. At this incredibly stressful time, families need information. A study by Lemon and colleagues in 2016 identified significant communication challenges for families at this time of crisis. Families unsure of what was happening to their child, bombarded with medical jargon, and receiving only fragmented conversations when they were moved from site to site. To mitigate this, an information brochure is given to our families by our neonatal transfer team, explaining the terms HIE, therapeutic hypothermia, and why our babies need to be cooled. The brochure also provides community resources, legitimate websites like Hope for HIE, and support contacts like our Family to Family Connections, a peer mentor support program. Outreach education in our province has helped rural teams identify early signs of encephalopathy, but it's also provided them with a better understanding of our neuroprotective protocol so they can prepare families for the treatment and the care that's to come at the tertiary sites. We know that nurses are a significant source of support and have an important role in educating families as to what to expect during cooling and their family's NICU admission. Communication needs to be open, honest, and compassionate. And consistent caregivers can help provide continuity of care, familiarity, and reassurances for families. Parents are absolutely welcome to be present and participate in daily rounds and are acknowledged as an integral part of our team caring for the child. We provide families with family integrated care journals and encourage them to write down their questions for the medical team. Use their journals to just express their feelings or simply just record their baby's journey, whatever they feel like using it for. Families are provided with 24-hour EEG updates, whether there are changes or not, by our neurology team. We also have Beads of Courage program. Each bead has meaning, and the beads become a reflection of their baby's courage and strength through their NICU journey. For our cool babies, we also give them a little bear bead. Many studies have shown, of course, that parents who are able to participate in the care of their families experience less stress, have more confidence in their roles as parents, and feel a greater sense of control. In a study by H.I.B.E.R.N.A.T.E and colleagues, 26 of 31 respondents, that's almost 84%, commented that the bonding of their baby was compromised by the inability to physically touch and hold their baby during cooling. As part of our protocol, we encourage holding during cooling to facilitate and support that parent-infant bond. A safety checklist for holding during therapeutic hypothermia was developed to help guide nurses and support parental expectations whilst avoiding inconsistencies in care. That is, some nurses allowing parents to hold and others not. Ineligible patients are those patients that have severe PPHN, receiving high-frequency oscillation, and those who have active seizures. We do hold back on infants that are on vasopressors and babies that are in that rewarming phase. We teach mums and dads how to give oral immune therapy. I think you might know it as kind of milk drops given on a soother or a swab, and to participate in giving NG feeds. Parents are encouraged and offered guided support with their general baby care, like mouth care, diaper changes, and we encourage them to be involved in weights and even the auxiliary temp checks. We are lucky to have single patient rooms and accommodation for one parent to sleep overnight, so dad or mum can stay close to their baby. Newborns have an acute sense of smell, and studies have shown that odors form part of that complex bonding process. So we have Puggles, which is a combination of parent snuggles. These are 2 heart-shaped organic cotton scent cloths. Mums are encouraged to hold the Puggle close to the skin or sleep with it so that it picks up her scent, and then this can be left with the baby and has a calming, soothing effect. The other Puggle is a comfort for mum with the smell of her little one, which also helps stimulate lactation, and as we know, breast milk is best for growing brains. A study by Beatty and colleagues in 2016 reported that even just the smell of maternal breast milk resulted in lower cortisol levels and less crying during heel pokes. It's incredible to think that even the smell of breast milk can have an analgesic effect. Parents need to feel part of a team, and with information, knowledge, and guidance, they can be involved in decision making and advocate for their child. Mums can feel both physically and emotionally traumatized. We know that depressed mothers have an impact on the long-term development of the child. So it's so important to acknowledge the stress and anxiety and optimize support. Social work referral and early screening for postpartum depression and PTSD is important for these families. At ACH, we are lucky enough to have our own dedicated NICU social worker and also have peer-to-peer support through our peer mentorship program. This involves support from mums that have had similar NICU experience. Much of the literature actually says that should be engaged early for these families. We also have a program called Family to Family Connections, where peer support can be a phone call away when parents go home. A study by Nassif and colleagues in 2012 reported that rewarming the infant was described by some parents as a time of rebirth, a turning point. One dad even spoke of becoming a father twice. It's a time of celebration. We mark the time for rewarming on our whiteboards in the patient rooms, and so parents have a countdown to the end of hibernation. Despite the trauma, families are not really with us for very long in the NICU and may even be discharged within a week. So we designed a specific neonatal follow-up integrated care pathway for infants with HIE to ensure that families received timely support and knew what to expect post-discharge. A study by Williams and colleagues in 2019 indicated that frequent follow-up visits provide the opportunity for parental reassurances, acknowledgements of their concerns, and ensure the opportunity for early interventions. These visits fostered positive parental perspectives on their child's outcomes and resilience, which was defined by parents as their child having less difficulties than expected, meeting or exceeding milestones. And parents were able to focus on their child's successes and not their challenges. B is for boundaries. Hypertonic, neurologically injured term babies need supportive positioning to maintain alignment and help promote sleep, control, and physiological stability, and support brain reorganization. Supportive positioning can be achieved with boundaries, providing containment, supported flexion, preventing that extension that you often see in these little ones, and maintaining that midline positioning. In a state of shock, an infant's blood pressure becomes pressure passive, and so babies lose the ability to auto-regulate. And midline positioning can really help avoid increasing blood flow to that, occluding blood flow to the brain. Take care of the environment. Nursing care of the infant should be well planned and coordinated to avoid overstimulation. A reduced stress environment helps minimize metabolic rates, preventing the risk of temperature elevation, increased intracranial pressure, and increased metabolic demands on the brain. Simple things like controlling noxious noise and controlling lighting can be helpful and keep the baby in a calm, nurturing environment. For our babies during cooling, we put up quiet signs. The American Academy of Pediatrics recommendation for noise in the NICUs is less than 50 decibels, and so we try and keep under that. Pages are put on vibrate. Phones are outside of the patient room, thankfully, and pumps alarms are attended to promptly. Patient alarms are turned down to low volume, with lower alarm lips set to an acceptable anticipated low baseline, because sometimes the heart rates may sit in the 70s to 80s range. This helps to reduce stress for both the infant and their family. Louder conversations take place outside of the room. When the transport team arrives with the baby, the handover takes place away from the bedside to keep the baby calm. However, we do know that conversational voice is really important for these little ones as well. There's a difference between noise and positive sound. A quiet conversational voice can be comforting and enriching for the family's brain, and hearing their mother's voice can enhance bonding and infant attachment. Studies have shown that low-intensity recorded maternal voice can lead to positive physiological responses, at least in preterm infants, with an increase in oxygen saturations and a decrease in heart rate and rest rate. It's really important that mum feels that she can speak to her baby and help relieve the separation anxiety for both mum and baby. Shared reading starts as soon as possible after birth and has long-term cognitive, social, emotional, and neurobiological effects, improving language development, reading, and literacy. At ACH, we have a bookworm program where we encourage parents to read to their infants for at least 15 to 20 minutes a day. Even our babies requiring neurocritical care get a quiet storytelling time. It's peaceful and comforting for the infant. And if mums and dads can't be there, then we can always get a friendly neonatologist dressed in a kangaroo suit to help out. Dialogic reading, or that interactive reading, is so important, even at a very early stage. If anyone was lucky enough to hear Dr. Horowitz-Kraut speak, you'll understand the benefit of this animated form of reading to your child. We teach parents to use this type of reading in the recovery phase, post the rewarming, and when they go home. It involves using eye contact, joint attention, and positive touch. Functional MRIs indicate that the white matter tracts of the brain become more organized in children that listen to stories. There is increased blood flow in the visual cortex of the brain. And you might see, why the visual cortex? Because positive sound literally ignites the imagination. Now, I'm not quite sure what babies actually see in their imagination, but I know they're always searching for their mum. The neuroprotective environment calls for indirect filtered lighting. Simple strategies like covering the baby's eyes with a soft cloth that the lights are turned on for procedures or assessments help to maintain comfort. The babies are kept in a dim ambient lighting for about 3 days during the cooling, but light should be gradually reintroduced post-rewarming to help normalize activity and reset those circadian rhythms. We need to let parents know that it's okay to start normalizing their infant and bring them out of the dark. The next thing is rest, recovery, and recognition. So it's important to be able to recognize that sleep-wake pattern on the EEG. So scheduled caregiving can be adapted to the infant sleep-wake cycle. If it is often difficult to assess sleep in a baby that is sedated or even encephalopathic. So we train our nurses to look at the EEG Studies in Thorson and colleagues indicated that recovery from a sleep-wake cycle in a non-cooled infant with good outcomes is usually within 24 hours. However, recovery of a sleep-wake cycle and a recovery to a normal background pattern in a cooled infant may take up to about 48 hours. And we do know that failure to show any evidence of a sleep-wake cycle is associated with poor neurological outcomes. So we may not always have the sleep-wake cycle to guide our practice, but if we can watch for it, we teach our nurses to adapt their care when they can. Our goal is also to avoid disruption to sleep. And as we mentioned earlier, that protective sleep is so important. Sleep plays a vital role in synaptic development, learning, and memory. And it's a time of reorganization of the brain. It's also an important indicator of brain health. As we know, when there's organized sleep wake cycle, it's a sign of a healing brain and recovery of neurons. And sleep wake cycle usually lasts about 20 to 40 minutes. Gentle handling during direct care promotes that calm, nurturing environment essential for the little one that's been traumatized. We want to see intentional nursing, if possible, guided by infant cues. We also want to avoid startling or rapidly waking the baby. Remember, don't poke that little bear, as this can lead to disorganized brain activity if woken abruptly from their sleep. Nutrition. In Alberta Rocky Mountain provincial parks, there are many signs saying don't feed the bears, but not this little cub. So during hibernation, at 24 hours of age, we start trophic feeds of 1 to 2 mils per kilo every 3 hours, as long as our lactates are normalized, and that would be less than 2. We continue trophic feeds for the duration of the cooling. Fresh EBM is preferable and not frozen or refrigerated to preserve the stem cells. Stem cells in breast milk are pluripotent, meaning that they have the ability to differentiate into other cell types, including neural-like cells, at least in animal studies. This has prompted more scientific studies into the consideration that human milk may not only provide immunological protection, but may also have a function in the development and protection of the human brain. If there is no breast milk, we may consider using donor human milk, but we do not use formula. Research by Therapeutic and colleagues in 2015 in a retrospective cohort study of NICUs in Sweden and UK looked at using similar hypothermic protocols, compared feeding practices to assess the safety and benefits of early minimal enteral feeding. There were no significant differences between the two groups regarding adverse effects, suggesting that minimal enteral feeding for moderate to severe HI infants was not associated with significant complications. A more recent study by Chang in 2018 reported no evidence of increased systemic inflammation when they looked at interleukin inflammatory markers. There was a decreased time on TPN. Babies achieved full feed sooner and were discharged home earlier, with no significant differences in MRIs. We need to provide positive oral stimulation with all our babes, and whilst they're not being fully orally fed, so offering soothers or providing oral immune therapy. And it's important to know that babies who have suffered a brain injury often require supportive feeding strategies, such as swaddling, side lying, head elevation, and pacing. Just like a preemie, babies with HIE can be also fragile feeders due to altered tone and a weak suck. They can have difficulties coughing, choking, pooling, loss of bolus, and an inability to handle those secretions. So we need to teach parents infant cues such as eye aversion, disengagement, yawning, and hiccuping when they're distressed. A recent study from South Africa by Kruger in 2019 reported signs of oropharyngeal dysphagia in 25 of 28 patients with HIE. 15 of those had mild HIE, 11 had moderate, and 2 had severe. These signs included things like falling asleep during a feed, visible oral secretions, coughing, nasal flaring, and an absence of frequent swallows and that single suck. Addressing feeding problems promptly with support from a trained speech language therapist or OT may help to avoid feeding struggles, oral aversion, and also placing that parent-infant relationship in jeopardy, as feeding difficulties present a very difficult challenge for families, especially when we're just sending them home so soon. A is for assessment. So a targeted neuroassessment is performed by the physician and the nurse, working collaboratively to minimize the handling of the patient and avoid stress of the infant. The routine cues 4 to 6 neuroassessment should be minimally invasive and incorporated in your head to toe. Documentation focusing on things like state of arousal and spontaneous movements, as well as the abnormal. So you don't want to do your whole assessment and then go back and say, oh, now I got to do a neuroassessment. And we don't routinely do pupil reaction because it can be quite stressful for the infant. And so, not forgetting, of course, our ABCs. When we're looking at airway and ventilation management, oxygen is titrated to oxygen saturations between 90 to 95. Not only do we want to prevent hypoxemia, which can lead to further neuronal and white matter injury, we also need to prevent hyperoxia, which can increase oxidative stress and free radical production, mainly that reactive oxygen species. With therapeutic hypothermia, there is reduced oxygen consumption due to a lower metabolic needs, and therefore an increased risk of oxidative stress and release of inflammatory mediators. Hyperoxia is associated with death and poor long-term outcomes, leading to alterations in development processes such as neuroplasticity and myelination. We need to monitor pre and post ductal SATs as well to assess for right to left shunting across the foramen ovale or the ductus arteriosus, an indication for persistent pulmonary hypertension. And in these cases, or the possibility of treating with inhaled nitric oxide. Oxygen saturation is not only affected by O2 delivery, but also by tissue O2 consumption. So monitoring cerebral oxygen consumption through near-infrared spectroscopy can provide further information regarding cerebral oxygenation. Overall, a higher cerebral regional saturations have worse outcomes. And we're just in our infancy stage here in trying to introduce NIRS into our unit. We need to avoid low CO2s or CO2s less than 35 or hypercapnia or hypercarbia, depending on which side of the pond you're living. There is evidence that hypercapnia leads to impaired cerebral blood flow due to vasoconstriction. And cellular alkalosis, which also can lead to worse neurodevelopmental outcomes because the seizure threshold is lower with alkalosis. Studies have demonstrated that infants with hypocapnia have significantly higher HIE changes on MRI and have increased odds of abnormal MRI. Many babies with HIE have a strong respiratory drive in response to a metabolic acidosis following an asphyxial insult, and it can be difficult to prevent that hypocapnia. Extubation is considered as early as possible, and gentle ventilation with volume guarantee settings will help try to avoid that hyperventilation. For blood gas sampling, our preference is to place an umbilical catheter versus use capillary blood gas sampling. We know that cool peripheral blood draws can give us those low pHs and higher lactates due to poor perfusions. And it's important to recognize that temperature correction with the blood gas machine may lead to underestimation of the PCO2 by about 10 to 15. So if your blood gas is sitting around in the 30s, you're probably in the right place in the 40 to 50s. Also, frequent gentle suctioning sometimes is required. You don't want to overstimulate the baby, but secretions can become thicker with hypothermia and restricted fluid intake. And we also know that hepatic dysfunction from asphyxia and therapeutic hypothermia can lead to coagulopathies with low platelet counts, prolonged prothrombin times. And so we need to observe hemoptysis and bloody secretions that you may see in these patients. And infants with HIE may already have respiratory depression, but others may develop respiratory suppression and apnea from seizures or high doses of anti-seizure medication, leading to the need for mechanical ventilation. So again, just gentle ventilation is required. So now let's look at our cardiovascular assessment. So we know that cooling can prolong the QT interval, and bradycardia is common response, with the heart rate sometimes going down into the 70s or 80s. Therefore, if the heart rate is in the 110 range, it's worth considering if the baby's in pain or distress, or is there a possibility of an infection, or is the baby having a seizure? So be attentive to the parameters that you might expect when the baby is cooled. Cardiovascular instability is common in HIE babies due to a decreased ability to regulate muscle tone, vasoplegia. With cooling, the systemic vascular resistance may be increased, and cardiac output in term babies has been shown to be 2/3 of their normothermic baseline. There is increased sensitivity to the myocardium to the cold. However, it's balanced by a left ventricular wall stiffness. So due to these myocardial changes, a slower heart rate, increased contractility. Therefore, the chronotropic effects of inotropes may actually be detrimental. Studies have shown that blood pressure is a poor indicator of cardiac output, so further evaluation is needed to determine cardiovascular management. We commonly will accept lower target mean BPs, greater than or equal to 30 to 41, even in our term babies. Further monitoring includes cap fill times. This is sometimes hard, of course, as the baby is cooled, so they have prolonged cap fill times. But anything greater than 4 and a little bit more is more of a concern. We need to get an accurate urine output, and also along with our acid-base balance, plasma lactates, and cortisol levels. Echocardiography is needed to look at ventricular function if you have hypertension. It's important to remember that cardiac output may be lower due to the decreased heart rate, but is still functional because of the reduced metabolic needs. We'll get a 12-lead EEG and possibly draw troponin levels to rule out any kind of myocardial injury. It's important to identify the cause of the hypertension. So consider hypovolemia, poor myocardial function, possibly due to PPHN, sepsis, or even high vent pressures can actually affect your cardiovascular stability. Trauma impairs cerebral autoregulation, so the blood pressure becomes pressure passive, and you may get surges of cerebral perfusion, causing further neuronal injury. So caution is therefore needed with normal saline boluses and inotropes. A retrospective cohort study done by Mohammed and colleagues in 2017, and that's our team actually here at ACH, indicated that the use of inotropes may in fact exacerbate brain injury in neonates with HIE. There was a consistent association between inotrope use and brain injury on MRI after adjusting for confounding factors such as illness severity, with a recommendation of cautious use of inotropes. A research paper by Joint and Chung gives a really thorough literature review of cardiovascular support therapies in neonates with asphyxia and the potentially deleterious effects of inotropes. So dopamine, for instance, can cause intracranial vasoconstriction and blunt cerebral autoregulation. Dopamine can increase stroke volume, cardiac output, and increase brain perfusion, which, although seemingly beneficial, can also increase the risk of further injury. And the alpha adrenergic effect of epinephrine leading to vasoconstriction can increase afterload, thus decreasing cardiac output, decreasing flow to the gut and kidneys, and is associated with increasing lactates and hyperglycemia. And we know that hyperglycemia in cooled infants has been associated with severe neurodevelopmental disability. Caution is really necessary when you're thinking about inotropes usage. However, we also know that hypertension can cause secondary ischemic injury. So asphyxia can affect the hypothalamic pituitary adrenal axis function. So our preference is to draw a cortisol level. And if the cortisol levels are low, we're talking less than 200, we treat with hydrocortisone as a first-line treatment before considering inotropes. Caution and vigilance is also needed during that rewarming, because sometimes your blood pressures can drop due to vasodilation. So it's really important to have that slow, controlled rewarming. But also, if the infant is requiring inotropic therapy, an infant's metabolic rate increases, as the infant's metabolic rate increases, so does the drug metabolism, and the effect of inotropes can suddenly be enhanced. So it just bears watching when you're monitoring your patients. Fluid balance. So for fluid balance, our patients may be restricted to a total fluid intake of about 40 to 50 mils per kilo per day. Strict monitoring of intake and output is needed. All diapers are weighed, and the baby may require a Foley catheter for accurate urine output. Babies are at risk of SIADH, so syndrome of inappropriate antidiuretic hormone secretion following an asphyxial insult, which causes the body to retain water. So it's important to report oliguria immediately, reflected by a urine output less than 1 mil per kilo per hour. We need to be accounting for all our flushes and any fluid administration so that we don't overload these babies with excess fluids that they can't get rid of. In terms of our glucose and electrolyte monitoring, we know that anaerobic cellular metabolism and hepatic dysfunction may lead to hyperglycemia. So our HIE babies have decreased hepatic energy demands as you put them in that low metabolic state. Therefore, there's a decrease in gluconeogenesis and glycogenolysis. Recognize that we don't want to exceed the energy demands of the baby that's in this subdued resting state, as an excess of estimated energy requirements increases the CO2 production, which may increase ventilation requirements. So we want to provide nutrition and support for these infants with a resting energy expenditure of about 40 to 60 kilocalories per kilo. You need to monitor your serum blood glucose and avoid hyperglycemia. Our frequency of blood glucose monitoring is based on each of the preceding results until stable. So 2 stable results of greater than 3 millimoles per liter, or I think in your world it might be 54 milligrams per deciliter, not more than 2 hours apart. Then once they're stable, monitoring Q4. And that's why it's really nice for us to have an arterial line for access so that we're not poking the baby and disturbing them. We monitor, of course, our electrolyte for any disturbances. So we do a general electrolyte panel. And then we consider adding electrolytes into our parenteral nutrition after 24 to 48 hours once our electrolytes and renal function has hopefully stabilized. It's important to remember to add phosphate as soon as possible to TP and to utilize intracellular glucose consumption, decrease secondary energy failure, and prevent exaggerated hypoglycemia. And this is something we've built into our protocol to early on balance that calcium phosphate. Infection prevention, of course, is important for all of our babies. Most of our HIE babies are not related to cases are not related to sepsis, But all of our babies diagnosed with HIE and managed at our centers usually have at least a partial septic workup and receive empiric antibiotics for early onset sepsis for about 48 hours. A lot of these babies will have a central line in, maybe even a Foley catheter, and possibly an invasive airway. So we want to protect them from all of that and prevent the risk of infection. Strict hand hygiene practice is needed. And the drugs of choice for us are ampicillin and cefotaxime. We avoid gentamicin due to both ototoxic and nephrotoxicity. And cefotaxime has been shown to have a superior safety profile to gentamicin in patients with renal dysfunction. And since there is renal involvement in 50% of perinatal asphyxia cases, cefotaxime is our preferred drug of choice. So T, getting there, tools to help with our assessment and treatment guidelines. So routine pain assessment with a reliable validated tool is essential. So we use our NPAS, neonatal pain agitation and sedation score, but it's important to recognize that sedation and pain relief can be hard in a baby that's encephalopathic. So consider context and anticipate the need for pain medications during painful procedures. We do a Q4 pain assessment and more often obviously if it's indicated by higher scores. The infant with HIE may demonstrate hyperalertness and have a lower threshold for stimulation, which we typically see in those kind of stage 1 HIE infants. We need to be vigilant in our management of pain and stress during and after procedures with multimodal measures such as containment, facilitated tucking, positive touch, non-nutritive sucking, and of course consider that parental presence and a scent cloth with that maternal smell to help improve the comfort and support the infant. The role of sedation is actually to reduce elevation as well of the baby's body temperature so that it doesn't impede the goal of therapeutic hypothermia. Animal studies suggest that shivering and elevated stress levels may undermine the neuroprotective benefit of hypothermia. So asphyxiated piglets were cooled and not sedated, unfortunately, and were shown to have higher cortisol levels. Corticosteroids released during stress can lead to further energy depletion in the brain, making it more vulnerable to seizures. So important our infants are comfortable. As I mentioned, opioids help blunt the stress and metabolic responses to hypothermia. In our protocol, we use low-dose morphine. A study by Freemeyer and colleagues in 2017 indicated that morphine clearance is markedly lower in infants receiving therapeutic hypothermia when compared to normothermic infants. It can be decreased as much as 50%. We use morphine 5 mics per kilo per hour, as a low dose can achieve a dose equivalent of 30 to 40 in a baby undergoing therapeutic hypothermia. There have been extensive studies on the use of morphine in infants and its safe short-term use. We stop the infusion prior to the rewarming phase because as the babies warm up, they may metabolize the morphine more readily. And we have seen that in our infants where they actually seem to be hypoventilating a little bit in that rewarming phase. So a decision was made to stop it before we start warming. Morphine has been proven to be effective in the reduction of shivering. And our overall goal is sort of sedation to help quiet that brain. Fentanyl can have less side effects in terms of respiratory depression and hypotension compared to morphine, but there is a greater risk of tachyphylaxis and a tolerance and a diminished effectiveness of fentanyl regardless of the dose and how long you've been on it. And so we try to avoid fentanyl in these little ones. There have been some studies in dexmedetomidine. Animal studies suggest that it may provide some degree of neuroprotection, reduce cellular apoptosis, but there's no long-term studies in cool babies. McAdams and colleagues in 2020 also reported that there was a slow rise to reach plasma levels in cooled newborn babies with HIE. It took about 24 to 48 hours to reach a therapeutic dose. And they put that down to the absorption of the drug into the IV tubing. So they recommended that a loading dose be suggested. However, there is a risk of bradycardia and hypertension with dexmedetomidine. And so we try and avoid giving sort of a loading dose of that particular medication. And at present, our neonatal neuro special interest group looking at Canadian benchmarking and best practice felt that at this time, with limited pharmacokinetic studies on the long-term effects of dexmedetomidine in cool babies, that had already been exposed to a brain injury. We needed more long-term studies looking at the long-term effects. And I believe there is actually a new clinical trial starting this year from a team in Utah, the Dexmed use in infants undergoing cooling due to neonatal encephalopathy, the DICE trial, hoping to look at the long-term safety and efficiency of dexmedetomidine in neonates with HIE. So there is new knowledge coming on the horizon, and I think they're looking at results in kind of 2024. So looking over a period of time. We do a skin injury assessment, a score and we've used SIRA is performed just using a reliable tool to really assess for any kind of skin injury, because we know these little ones are at risk. We know that birth asphyxia triggers the diving reflex, and blood is shunted from the skin to the splenic beds and to the heart and the adrenal glands. For prevention of pressure sores and ulcers, all skin surfaces that contact the cooling bed are assessed Q2 to 4 to detect possible skin breakdown or subcutaneous fat necrosis. It's important to remember that babies can also get skin breakdown under their EEG leads, because we use little cup leads, and so we have to be careful that they don't get pressure sores there. The infant's position is changed at least 1 to 2 hours to prevent discomfort of skin breakdown due to prolonged tissue pressure. And that just involves a subtle kind of roll and just tucking a sort of a little blanket underneath. So we don't have to wake them up for that. We just gently rotate them. And using gentle handling is to provide direct care is really important. And even some babes, as we know, that are in severe kind of PPHN as well, may need pre-medications to help support them while repositioning. Subcutaneous fat necrosis can present on areas as firm, mobile nodules and plaques overriding mainly the sort of bony prominences, or like on the buttocks, the cheeks, the trunk, and the cheeks. It usually appears in the first 7 to 10 days. It's self-limiting and will commonly, hopefully, disappear by 1 to 2 months of age. Higher tendency of crystallization of neonatal fat following hypoxia, because it got a lot of adipose tissue, and it has a higher concentration of saturated fatty acids, and that's why we tend to see it in our babies when they're cooled. Risk factors on the maternal side also include diabetes. Those mums tend to have large gestational babies with lots of fatty stores, hypertension, and preeclampsia. The neonatal risk factors are also asphyxia, traumatic delivery, shoulder dystocia, because prolonged delivery, meconium aspiration, macrosomia, and the need and the use of inotropes. So complications from subcutaneous fat necrosis, it's actually reported as not being painful, but for some of our babies, it does appear to be painful, can cause some scarring, and the big risk is hypercalcemia. There is incidences of thrombocytopenia, hypertriglyceridemia, and anemia. But we know that HIE increases the risk of subcutaneous fat necrosis and not cooling, because that was evidenced by studies such as the CoolCap trial, because they did head cooling only, and those babies also developed subcutaneous fat necrosis. So strategies that we've implemented to reduce this are decreased use of inotropes, the decreased vasoconstriction, early TPN, early feeding, a balanced phosphate and calcium to prevent hypercalcemia. And we use a blanket wrap, which allows for holding and ease of changing the baby's position. And it also has a pressure relief motion of the blanket cells. And it seems to be helping. We are also now in the process of developing a provincial standardized treatment protocol, so our team can act promptly and stop the seizures. So we know the goal of seizure management is to stop the seizure burden. Delaying the treatment of seizures can further brain injury, and it makes them actually harder to stop. Our first-line anti-seizure medications include phenobarbital and lorazepam, then followed by levetiracetam or Keppra, and phenobarbital again, or phosphonatoin. And for refractory seizures, we tend to use midazolam. E is for EEG. So all our level 3 nurses are trained to apply leads as soon as possible following admission to the NICU. We know that 80 to 90% of seizures and even status epilepticus in newborns is subclinical. So it's important to get the leads on. We don't have 24/7 EEG coverage, so training our nurses guaranteed prompt CV EEG monitoring. Our nursing team are taught strategies to optimize the EEG tracing with impedance checks every 6 hours. Continuous observation of the EEG by the bedside nurse is expected to flag any suspicious events. We use amplitude EEG pattern recognition to report any changes in background patterns and adapt the care, as I mentioned, the care schedule of the infant as necessary. And of course, we can optimize early seizure detection. Astute observation by nursing of subtle changes can contribute to prevent further brain injury. So in a research study by our own neurocritical care team here at ACH, we found that following a training program for our nurses on the application and interpretation of continuous video EEG, there were improvements in the time of initiation of EEG monitoring. It went from 39 hours to 7.5 hours. And the availability of brain monitoring for all infants, irrespective of the time of admission, which ensured prompt management and a more accurate diagnosis of seizures, which actually resulted in a decrease in the need for anti-seizure medications. And we had more infants discharged home without anti-seizure medications. It went from 70 to 37%. In animal studies, phenobarbital and phenytoin have been shown to induce apoptosis in rat brains when developing neurons are growing rapidly and establishing synaptic connections. So if we can avoid using unnecessary use of anticonvulsants, it's a really good thing. Mortality dropped from 12.5% to 5.4%, and significant brain injury on MRI went from 42 to 18%, and our babies went home earlier. Overall, the training of nurses to place the leads with the expert support of our EEG technicians in optimizing a good signal quality and the interpretation of our epileptologists, along with the guidance from our neurologist in terms of the management and prognosis, has created an incredible neurocritical care team, providing our families and their infants with the best quality of care. So in summary, standardized focused neurocritical nursing care can leave a positive, lasting impression on both neurodevelopmental outcomes and an infant and family's quality of life. So I just want to share with you a little short case study on baby T. So baby T is 38 weeks. She was an appropriate gestational weight and age. Fetal heart rate decels were present on delivery. She unfortunately was born flat, apneic, and had no spontaneous rests. Her APGARs were 1, 1, 4, and 5, and her core pH was 6.88. She actually had severe hypertension, and despite our best efforts, got a normal saline bolus. She received blood, and she was started on 2 inotropes. She was ventilated for 6 days and had severe hypocapnia, and so the lowest CO2 was 23. And we also had to treat her for hyperglycemia. So everything that we wanted to try and avoid. So clinical gave her a diagnosis of moderate to severe HIE. This is what her EEG looked like when she first came in. So within the first 24 hours, she stayed in burst suppression. And when we did an MRI, this is what it looked like. And so this was on day 4. And so the bright spots on the MRI show the areas of injury. And this was reported to us as total asphyxia. And the parents were given a very grim prognosis. And so now this is a little T at 2 years old. And this is her at 2.5 years old. I just love watching her. And then this, in fact, is her now at 6 years old. Despite facing significant clinical management challenges, this little girl continues to reach beyond our expectations. I truly believe that focused neuroprotective nursing care helped this little one reach her goal and full potential. And of course, the love and guidance of her amazing mum and dad. And through standardized, focused, evidence-based neuroprotective care we provide our NICU families, we can really make a difference. Thank you, everyone.
Oh, Jan, that was incredible. I think part of everyone's eval is to put that there should always be a cute video of someone
I think so.
with their dog being in the way. That's great.
I know. I love when she pushes the dog away. Stand back. I'm doing this.
And also, I think the biggest takeaway of the conference is that everyone needs to go back to their units and say, we need people in kangaroo suits to come and read to all of the babies. I think.
Yes, I think so. It's usually me in the kangaroo suits, but I chose to use Corshid, our neonatologist. I'm like, you're going on the screen this time.
That is amazing. I love it. Okay, let me get professional and look for some questions. We've got some questions from our group. Let's see, Liz Zimmerman. She's wondering, how do you stabilize your AEG wires, umbilical lines, catheters, rectal probes, all of that so that parents can hold your babies?
Okay. Yeah, no, we're lucky enough. We have a brain net. And so it's like a little map that we put on. And then we have the cups. So we don't have needles. And then when we do that, we then wrap the whole thing in gauze. And so we've completely circled, and it works really well. Like, it really keeps them in place. Our umbilical lines, we have a special kind of a stat lock that we put on, and it's super secure, but we are very careful with our lines, but we don't want it to limit parents holding. And so we just then stick it down to our diaper. And having been a transport nurse and transported these babies across many miles, it is doable. And I just think you just have to be careful and just double resecure it in the second place. And so that's the type of thing that we've been doing. And we also have a special sort of little device that we put on for our urinary catheters, and they've worked really well. I know that we've gone through quite a few of them to make sure that we got the right ones, but it's worked well, and it really is just so valuable to get those little ones out for the parents to hold. We put a pillow between them. We messed up the first time because we just handed the baby to the mum, and then the mum's arms got frozen. So you have to be a little bit cautious about that, because it actually sometimes feels quite warm to touch, but of course it cycles, and so we just want to protect mum as well. But in hindsight, yes, we learned from that experience.
That's awesome. Let's see. Have a couple more questions coming in. I think Sharon did an emphasis on the education for staff.
Yeah, I was like,
a question I had when you were talking about the CV assessment and trying to decrease your use of inotropes, I was wondering for all of your babies, and just to get ahead of the game to try not to get to the point where you need your inotropes, do you like a baseline, like everyone gets a cortisol level, just to see if you want to just go ahead and start hydrocortisone?
We do. Yeah, we do. And we've really started that recently, because what we found was we are worried a little bit about hypertension, and then we were doing echoes more and more. And then for some of our sort of less experienced sort of fellows, they were doing just T&Es. So in the moment kind of echoes, looking at a functional T&E, but not remembering that the cardiac output will be reduced in our little ones, and that can still be functional. And the study that our team did was over 7 years. And so they had about 221 patients in that when they looked at the effects of inotropes. And they actually took out the mild and they took out the severe HIE, because I questioned that too and said, wouldn't they need inotropes, and wouldn't there be risk of death and injury be higher just because they're the severe asphyxia? But they actually took that into consideration and still found that inotropes had a significant sort of effect. And so there was an association with their use. And so for us, we've decided to do the cortisol levels. And I know some units will use from 400 as a sort of a low cortisol level. We actually go with less than 200, because we do know that the HBA axis can be affected. And so we're using that more. There is a risk with the hydrocortisone as well, that it can cause hypoglycemia, of course. And so we're checking for that. But we use kind of small stress dose, and usually once, and then we'll follow up if we find that the cortisol level's dropping. So, yeah.
Do you usually put them on maintenance for a while, or do you just follow the level?
It usually is just a stress dose, because it's usually, we find it's just in that first 24, 48 hours that they have this kind of, the BP is vulnerable. And that's obviously at that time in that first 72 hours of reperfusion injury that we're really concerned about. And so in that latent sort of stage, so second stage. Yeah.
Fantastic. Everything we all want to do for each of our babies. Thank you for us.
Thank you so much. Thank you. Yes, it was fun doing it. And when I look back, and our team loves it, and it just guides your practice and includes all that management that we as nurses, I think, at a higher level are looking for, right? And informing our physicians. So, but thank you so much for that.
Yeah, I think it's great. You can use all those tools just dealing with all of your NICU babies, not just your HIE.
Yeah. And it just gives value to what nurses are doing, right? Because we're reporting it, we're writing down the numbers, we're noticing. And I just think it takes us to that higher level, right? That we are the frontline person and we see it before our physicians know about it. And it's just having that understanding of what's going on in your baby, and some of the things and some of the treatments we're providing. It really helps us to make a conscious effort and deliberate effort to improve outcomes.
Fantastic. Just seeing if we have any more questions come, feel free to put them in the chat and we'll get them up here for you. Just a quick question, Jan, even since instituting this and just having this HIBERNATE thing for your colon babies, and it sounds like you have really good ways that you can incorporate the parents into this. How have they taken to being able to do all these things? I know a big thing in NICUs is, the parents never know what they can do, but it sounds like with your program here,
Yeah, we do have a family integrated
The
care
parents are super
program
with their
here.
HIV.
And I'm a chair of the Parent Partnership and Care Committee. And so to me, it's very dear to my heart. And so we do want to give options, and our families have loved it. And a friend of mine, actually, a friend of hers had a little one that was in another hospital and was cooled. And she said, just think of it like hibernation. And then she came back to us with the sort of feedback saying that made it so much easier. She said it was just so horrible because the baby looked like she had died, essentially. That's essentially what it feels like, right? Because it's so unnatural. But she said, when I thought about that, I thought that makes it better, right? And our parents love this countdown. We put it on the board, and then we do try and celebrate. And I know that a lot of these little ones will have long-term outcomes, but I think we still have to give them hope, that we still have to give them sort of that sense that things may get better. And we know that when babies warm up, they get quite animated. And it just, I think, gives them those coping skills and definitely helps them bond with their infant so they're ready for the challenges ahead. And so it's just really incorporating them from the get-go has been amazing. We do have single patient rooms, and so that's so lovely. And I will find we've had some mums that it's just been like a bedside vigil. They've stayed, they've been welcome to stay. We've let them know if they've communicated with us, if the baby's had any kind of abnormal movements, especially in those babies that have got some sort of tonic movements. And I think it's about education. I think it's about giving that to the parents. And when they feel involved in care, they feel that they're not the outsider looking in, and it makes it less scary, and it gives them something to do. It really does. And we've really incorporated this reading a book to their babies and brain development, and they love that. I will say a lot of the parents, when you ask them, say they're not really learning to read. Like, I feel silly just reading to them. And so we've shared all of that information with our parents that can start in utero. And so all of that stuff that we learned last week about brain development and forming those synapses and just building kind of the full potential of their infant.
That's so fantastic, Jan.
Yeah.
I think that's what we have for questions.
Thank you so much. It was such a pleasure.
That was amazing.
Thank you. Thank you.
Absolutely.
Wasn't that an amazing presentation by Jan Lind? It is one of my favorite presentations from the entire 2021 conference. It is so filled with practical bedside pearls that all of us can remember and implement in our care of babies with HIE. So I love that she has this really easy to remember acronym, and yet it is so comprehensive of all the things that we need to be thinking of as we're taking care of our babies. So it is just my pleasure to be able to bring these presentations back from past conferences, from community calls, and other various events that we've done over the last 5-6 years, and to bring them back to you here on our channel. So if you haven't already, go ahead and click that subscribe button, hit that notification bell so that YouTube can tell you when we post new videos. And it really helps us out a lot. It helps us to be able to bring more free content to you and the rest of the world. If you missed any of the previous videos, go to our channel and hit that home button and you can see all of them. And stay tuned for more videos on cooling babies with HIE. And I will see you next time. Bye.